Hi, everyone.
Thank
So
you.
we'll kick off now the second session, which is AI for clinical management. Our first speaker is Professor Collin Stultz. Collin is a professor at MIT in the Electrical Engineering and Computer Science department. He's also in the Institute for Medical Engineering and Science. Collin, as his slide shows here, is distinguished among MIT faculty for many reasons, but particularly unique about him is that he is both a clinician and an engineer. And as such, he provides a very interesting perspective to many of the clinical challenges that we have and face today with COVID. So without further ado, Collin, please take it away.
Great, thank you so much. Let me see if I can share my screen and share. Good. Can everybody, can you see that, David?
Yes, but I recommend
Okay.
making full screen. That's perfect right there.
Yeah, great, thank you. So today I'm going to try to give you a little spin on some initial work that we have done in trying to answer some unmet questions in the care of patients with COVID-19. So just as a refresher, something that I don't necessarily need to show here, but we all know COVID-19 is caused by a novel coronavirus, SARS-CoV-2. Hospitalized patients typically present with some form of pneumonia. And what's interesting about this is that a significant fraction of patients, about 20%, go on to develop acute respiratory distress syndrome, which is a very severe, often end-stage respiratory complication that can be quite fatal. Now, for reasons that are not clear, COVID patients have a slightly different course than a typical pneumonia ARDS course. So they can start and progress along. Here, if I'm sort of depicting the time 0 is their admission. This is their time within the hospital. And you can see their O2 requirement here. So how much oxygen they need to maintain an adequate level of oxygenation in the blood. For some period of time, they drift along and they're fine. But then at around day 6 or 7, they develop an increasing O2 requirement, respiratory distress, and end up intubated maybe a day or two later. So it's a very rapid course here. And this is deceiving because it's hard to notice from this time course early on, where patients are doing quite well, that they're going to end up here intubated. And that is a significant problem in the management of these patients. In particular, it's hard to know who is going to end up in the ICU, who is going to be intubated, and who's going to just have a pretty benign course for 10 days and then go home. Moreover, once these patients are intubated, the mortality is quite high. And depending on what study you look at, it's between 23% or 65%. I think some of the earlier studies from Wuhan, about 65%. Some of the later studies out of Italy and those in parts of the US, about 23 or 28%. But nevertheless, these numbers at either end of the spectrum are quite high. So early identification of those patients who are at highest risk of ARDS and being intubated, I think would be helpful because it would enable appropriate triaging, management, and potentially early interventions. There's been some work that has been relatively recent to show that certain types of steroids can actually have a significant impact, beneficial impact on the course of these patients. There's a question about whether these interventions, if administered early in high-risk patients, would improve their outcomes. So our objective was to identify patients at high risk of being intubated using data that are easily available early in their clinical course. So what data sets do we have to bring to bear? Well, Mass General has a COVID-19 retrospective data set that is quite small. It's about 800 patients, about 200 of them became intubated and such. So there are disadvantages here. It's a small data set and it's obtained from a single quaternary center. An advantage, though, is that it's well curated and all events have been clearly adjudicated. What we found is that oftentimes when combining data for these sorts of questions from many different sources, the level of data, how good the data are from different sources are not always clear. And it makes it very hard to train algorithms to answer clinically meaningful questions in that sense. So this data set we have to start from. What can we do with it? Well, do what I think most people would do at the outset. We looked at the variables that are routinely collected in patients who are admitted with COVID-19, and we identified about 17. So, and they're listed here, some of them: temperature, systolic blood pressure, things that are obtained from essentially everyone. Glasgow Coma Scale, not that often, but there are other ones in terms of lab values as well that are pretty much well represented within a data set. There is some degree of missingness here. So I alluded to this Glasgow Coma Scale, and there's some other types of lab values, troponin, procalcitonin. But we wanted to see how well we could do just by using these variables themselves. You put them into a standard logistic regression model. You impute the data that are missing and seeing how well you could do for the problem of predicting who will be intubated at some point during their hospital course. And the AUC for this type of task is between 0.71 or 0.76. I'm just showing you a representative one from one particular trial here. So now there's some limitations here. So this number is not great, but it's approaching the point at which it can be clinically useful. If you look at most of the discriminatory ability of clinical models that are used in practice for hard problems, 0.7 or 0.8 is typically where most of them settle out. However, the data, as I've already mentioned here, is a number of missing entries. We have to do imputation that limits sort of how one can interpret these results. And I think more importantly, the data itself contains a mix of patients who were intubated early and some who were intubated later. So because MGH is a quaternary care center, we get transferred patients who cannot be cared for adequately at their home institution. So some of these patients come in and they're quite sick, and they're intubated very early. So and what we found in practice is it can be very easy to get high discriminatory ability for events that happen early in time. So for example, if a patient came in and their heart rate was 20 and their systolic blood pressure was 70, you really don't need a complex algorithm to say that that person's going to die at some point in the near future. And for that cohort, you could actually get a very high discriminative ability and get very high AUCs. But if you restrict yourself to the cohort of patients for which really the issue is not clear, that their initial signs and presenting symptoms do not suggest that they are at risk of an adverse event to the clinician, but nevertheless, but that patient will develop, be intubated 6, 7, or 8 days down the line. If you look at those patients, the performance is significantly worse. So it's hard to make progress on such a small data set. So given a relatively small size, can we exploit our understanding of physiology and other larger data sources to build more predictive models? So in this vein, I think there's one thing that is pathophysiologically a common occurrence in patients who develop ARDS. It's called hypoxic pulmonary vasoconstriction. So the lung, when let's say you have a bad pneumonia and you're not ventilating very well, the vessels that go to the lung, to those areas that are not being ventilated, they constrict. And you can sort of understand that is that the body does not want to send blood to areas of the lung that are not being ventilated. So it wants to shunt blood away from that. So it's a standard response that we know and is well described in animals and in people within the pulmonary vasculature. So these patients that go on to ARDS, hypoxic pulmonary vasoconstriction is sort of a common mechanism here. And those patients have a rise in their pulmonary pressure. So the pressures in the vessels that go to the lungs go up because the resistance in general goes up where they're not oxygenating. So if we know this, can we instead try to get at the pulmonary arterial pressure as possibly an early indication of respiratory decomposition? And if we could decompensation, and if we could estimate that from readily available data, would that be useful? So instead of going to the small cohort of COVID-19 patients, can we leverage this understanding of physiology to bring to bear larger data sets where pulmonary arterial pressures are measured, and then make with the task of estimating these proxies that we think precede going into being intubated. So can we predict pulmonary hypertension using data that be available for virtually all patients admitted with COVID-19? And So this is, I think, where the electrocardiogram comes in. So the electrocardiogram, I think as many of you know, is a standard of care. Almost every patient who gets admitted with COVID-19 gets an ECG. In fact, in Mass General, it's part of the protocol because somewhat parenthetically, we know that COVID-19 affects the heart in many, many ways. And some have even argued it's more of an endothelial disease. It's cells that line the heart and blood vessels more so than a pulmonary disease. So all of these patients get electrocardiograms. And so we would like to use the electrocardiogram to diagnose and to get an estimate of the PA pressures and to understand when the PA pressures are elevated. Again, the goal here is if we can do that, then we can transfer that information to the small data set to be able to predict respiratory decompensation. Now, the way that pulmonary hypertension is typically diagnosed now is with the gold standards of right heart catheterization. It's an invasive procedure that entails you have to put a catheter into the great vein. It requires some expertise in placement and consequently is subject to some complications if an intern is doing it. And you're probably at a higher risk of complications than a fellow who is much more a cardiovascular fellow in training that's much more experienced, or an attending who's done it a lot of times. Another way that you can do it is with cardiac ultrasound. It's not an invasive procedure, and you can estimate the pulmonary arterial pressures there. But again, that does require some expertise in sonography. It's not an easy task to be able to point the probe, know where you're looking, and to be able to get an estimation of the PA pressure. And you have to make some assumptions there. So the ECG would be useful because it doesn't require this expertise. It's a non-invasive procedure. And we think it has some promise here because the ECG has been useful for calculating other types of metrics that indirectly provide information, what we call the autonomous nervous system, parasympathetic and sympathetic system, which influences the PA pressures. And as a case in point, if you took a look at the ECG and you calculated these heart rate variability metrics that can be calculated directly from the ECG, and you tried to predict the PA pressure from it, whether the PA pressure was elevated or not, you get an AUC of about 0.6. So it's not great, but there's some signal there. So that HRV alone weakly discriminates between patients with and without pulmonary hypertension. And there are other things also about the ECG that would lead you to believe that it's good for this task, because pulmonary hypertension leads to changes in the structure of the heart that you can often tell with an electrocardiogram. So our hypothesis was that the ECG contains information that can identify these patients. So this is where we can now bring larger data sets to bear. We constructed with our colleagues in the Division of Cardiology a data set consisting of about 12,000 patients who underwent cardiac catheterization for a variety of different indications. So for these patients, we know that their PA pressures, because they've been measured using the gold standard approach. And from this subset, there are 4,000 of them that have ECGs on the same day as a catheterization. So we'd like to pair the ECG on the day that they have the procedure as the input data and in a supervised learning context where one is trying to learn the PA pressure in particular in a binarized way, whether it's elevated or not. Of these 4,600 patients, we've got 3,000 who have a complete set of hemodynamic measurements that include PA pressures as well as other pressures that might be of interest. So this is larger than the 800 that what we had in the COVID-19 data set, but it's still, in the total context of deep learning, it's not a large data set. So what we do is we pre-train whatever model that we're interested on a larger set of 200,000 patients. Again, from ECG, all having ECGs, from MGH, and we want to use that to develop some abstract representations of the ECGs that would be useful for this task of predicting the PA pressures. So we start out with a general, CNN. I'll just go through this briefly. We have it's a convolutional CNN. It only has sort of one convolutional filter. It's got 32 channels with, and this is just for the sake of completeness. And with just one convolutional layer followed by multiple rounds of max pooling, a dense block, we get finally our output, which is related to different metrics that are used for HRV. So since we start out with the ECG, we have our convolutional neural network, and we end up trying to learn abstract representations here that can at least reproduce different heart rate variability metrics, or I should say things that are used to calculate different heart rate variability metrics. You know that the heart rate variability is weakly predictive. It's a weak signal. And we want to ensure that at least this abstract representation is able to keep that information. The pre-training, it's able to reproduce the intended things quite well. The heart rate, QRS interval, PR interval, QT interval, these are Pearson correlation coefficients, are all above 0.9. So now that we've got this model, we think we've pre-trained it, we just do sort of a standard thing that's done in transfer learning. We chop off the last part and we keep the first model that generates this abstract representation. And then we append it with some additional layers to predict the PA pressure. What is different about this task is that we not only predict the PA pressure itself, but we predict other things, other hemodynamic quantities that are of interest. So that's the pressure in the pulmonary arteries. We predict what's called the pulmonary capillary wedge pressure. This is the pressure in the left atrium, the cardiac output, the pulmonary vascular resistance. And I'll say why we predict these other things, why this is important as well. So we want to predict not only the PA pressure, but a full hemodynamic assessment of the patient. So we predict the PA pressure and these other components in a multi-class setting. All of the outputs are binarized by this is the definition of pulmonary hypertension is above 20 milliliters of mercury, and all of these are cutoffs for the upper and lower limits of normal.
Collin, we're going to want to move on to the questions very soon, okay?
Oh, okay. I thought I have like 3 minutes. I thought I had 3 minutes. Oh, I'm sorry. Yes, I am over. Okay. So anyway, sorry, David. So I'll finish up quickly. So yes, we have an AUC of about close to 0.8 for this setting. And the reason why we predict these other quantities is we know that we can relate the PA pressure to the cardiac output, the vascular resistance, the pulmonary capillary blood pressure. The upshot is this: we can predict the PA pressure. We have these other components. When all of these measurements are consistent with our prior physiology, understanding of the physiology, we can say that we know the model is correct, or we believe the model is correct. And when they're not, the model is not correct. So we can make a prediction, but we can make statements about when we think the model is right about a given prediction. And these plots just show that when these four values are all inconsistent with our knowledge of physiology, that yes, the model is more wrong than when they are. So I'll leave it there. So the next steps are going to want to combine the ECG with laboratory data for predicting respiratory compensation. We're going to do this in a prospective manner using these methods. And these are the people who actually did the work. Nate Diamond did a lot of the pre-training. Daphne Schlesinger built a lot of the CNNs. So sorry for going on.
Thank you so much, Collin, for the talk. We received a couple of questions via the Q&A that I'd like to call out. The first one has to do with your original model that you presented for predicting probability of needing intubation. The question asked about how changes in practice patterns, for example, recent additions of dexamethasone or remdesivir to standard of care, affect both the data that you collected and as a result, the model that you learned.
Right. So these data were acquired before either of those were approved, and it certainly were acquired before the very promising results on dexamethasone, which is why so that is a proviso here, and which is why we'd like to, because as practice patterns change, the model needs to be revised with additional data sets that represent different distributions, which is why this has to be done in a prospective manner and continually updated.
The second question is with regard to the second part of your talk on using ECGs. The question is about whether it's possible to use the ECG signal to directly predict whether a patient would be intubated or more generally to deteriorate, and perhaps what the linkage is between that part of your talk and where you hope to go with bringing it to COVID.
Right. So I think some of this is a question of the data that one has, because we have a small number of patients with a relatively small number that have been intubated within this 5 to 10 day time period. That directly learning from the ECG is a challenging task, because finding those relationships with a small amount of data is just not happening. And we've tried that actually, and that's not been that fruitful. What has been much more fruitful is trying to trade it for a related task that you think is relevant for the intubation task. It's sort of a standard transfer learning way of approach. You have a large data set. you try to train it to accomplish some task you think is related to intubation, and this is the PA pressure, train on those data, and then you fine tune the model for the smaller data set.
But I might have missed something. Did you talk about how you fine tuned the model for the smaller data set?
No, I didn't talk about that. We were sort of cut on time, but most of that actually is going to be done prospectively. So we have a model now for which we've trained both. We'd like to combine the ECG data with the actual data from the COVID patients that produced the AUC of about 0.7 into a single model that we hope can be predictive in a prospective, tested in a prospective way.
And last quick question, you spoke about how it was so important to use the MGH data, which we understand very well, was very well abstracted, but yet which had very small amount of data, only 809 patients. What would we need in order to start to bring together data sets from multiple institutions? What would be the first thing that we would need to do as a community?
Right. So I think bringing together data from multiple institutions has advantages, but I think that it has some, and I think it needs to be adjudicated and cleaned up in a manner such that you can actually trust the data that lies therein. So I think first there needs to be a collection of the raw data, but then there needs to be bodies and eyes by clinicians who can go back and adjudicate the actual events that are there. And that's just a challenging task. Pooling data together, as you know, David, more data doesn't always mean better results.
Thank you so much, Collin.